Randy has been one of our contacts, one of our community partners, and they provided some really wonderful speakers for us in our speaker series. And Randy is with Homewatch Caregivers, and she is the Director of Community Outreach and Client Care, as you see on the screen. She's an MSW, and she's going to be talking today about a subject that a lot of people don't like to talk about, but it always comes up in conversation. What if? What do I do? And unfortunately, it's one of those things where people wait until it's too late to have the conversation. So this is something, plant a little seed for the future. Some of you may know somebody in an assisted living or a nursing home. It's been a really, really rough time for people that are in facilities because, like you probably know, long-term care and assisted living places got really hit with COVID. It sort of ran through like wildfire. And so a lot of people, because of that, are opting to, or because people aren't taking new clients, or I don't know what's happening on that level, but a lot of people are opting to stay at home after surgery instead of doing in-home PT, OT. People are trying to recover at home and also age in place at home. And sometimes you need a little assistance as you get older. And this is a way you can do that. So you may not need it now, but it's something to kind of keep in your brain for the future, or for if you know somebody that is getting older that's having a hard time and you find yourself being called upon to help and you wonder what kind of advice could I give, you might be able to do. So without further ado, Randy Brockman, welcome. Thank you.
Thank you so much. I'm here today with our nurse, Karen Frank. She's a nurse supervisor of our clients as well as a pastoral care nurse, and she's going to tell you more about that. But I wanted to thank you, Michelle, for inviting us back. It's been a pleasure. I think we met last November or December, and we've really enjoyed working together with you in getting new information out to the community. And thank you for that introduction, because I usually start my talk saying, well, we all hope to stay healthy and independent as long as we can. Injuries, surgeries, things happen in life, and home care is usually something we don't discuss until we really need it. So to be invited to come and talk to you about what is home care and how does it work, to give you a little bit of understanding of the services, Karen and I are happy to do that. So we're both from Homewatch Caregivers, and Homewatch Caregivers serves the Essex, Union, part of Passaic, and part of Morris counties. We began in 2009, and since then, Homewatch Caregivers of South Orange has provided 2 million service hours to over 1,200 clients and their families. We've developed a reputation as a high service, high touch provider. That doesn't sound great today in the COVID world, but we'll talk more about it. We have won all kinds of awards and received recognition for the care, the quality of work that we do. And most importantly, it's a great place to work. So we're also going to talk about that a little bit more. In terms of evaluation, there's a Home Care Pulse, which evaluates home care agencies. And we are proud that we have received the Leader in Excellence, both as a provider of care and as an employer for the past 6 years in a row. So I'm going to introduce you now to Karen, and she's going to talk about home health care.
Thank you. So I'm Karen Frank. I work for Homewatch, and also I'm a nurse in the community. I work as a pastoral care nurse for several synagogues in the community, and as a private client also. I take in pastoral care clients. Those are people who need to have somebody to talk to on a regular basis about what's going on with them physically, emotionally, with their illness, with their families, whatever is happening. So when I became when I was looking to work for an agency part-time, I went directly to Homewatch because I had been in the community long enough to know that Homewatch really was the one that I appreciated, as Randy said, their frequent touch approach, which means that we are very much in touch with the families and with the clients that we serve. So what exactly is home health care? It's really the putting of an assistant, an aide, a caregiver into the house to help people take care of what we call activities of daily living. And Randy's going to speak in a few minutes about exactly what they do. So what I wanted to look at first is one of the first questions I always get: does Medicare pay for this? And what do I get under that kind of service? Medicare absolutely pays for home care if a person has been in the hospital, has a new diagnosis, has what is called need for skilled intermittent care. That means somebody's broken a hip and they need a nurse to come out and assess the incision and make sure everything is going well with the blood pressure, things like that. And with that nurse comes a home health aide if the person also needs help in personal care, like with showers or making a meal or helping to get dressed. That service lasts for about 2 months at most after a hospitalization or after a major change in condition. The home health aide who comes into the house to help with the personal care also is only there for about an hour and a half a day. What most people find is that that is not enough if they have something going on like a broken hip. Once the person leaves after an hour and a half, they're on their own then for the rest of the day. That's when agencies like ours come into play, because we have private duty home health aides, which means you hire the aide for as many hours from 4 to 24 a day that you need. And it is not covered by Medicare. The only insurances that we do take, or any of the agencies like us take, is long-term care insurance and vet assist and stipends from some other specialized funding that may or may not be present. So it is a pay for hire service, and people can, as Randy's going to talk about, can customize the care for really what they need. The other option, of course, that I get lots of questions about is, what about hiring privately? My next door neighbor has this lovely woman and she pays her privately, and she has told me that she can work for me. How is it different? It's different in a few ways. A person who is in her own private business doesn't have the benefits, doesn't have workman's comp, doesn't have the kind of backup that we provide. There's no nurse making a visit, no social worker available to you. It's not a team approach. Homewatch has a very unique team approach where every client we have has a social worker and a nurse assigned to them, as well as their caregiver. So it is a very complete package that a Homewatch client gets, but they are still only paying the hourly rate for their caregiver. So even though I, as a nurse supervisor, makes a visit frequently and regularly, and the social worker is available by phone or for visit, The only fees associated with Homewatch are those hourly fees that are charged by how many hours you have the caregiver. So Randy, if you would like to talk about exactly what they do, that would be great.
Okay, I'm just going to skip a screen here. I just prepared this, but we sort of talked about this. This is just a general idea about home health care, and that it is the fastest growing job category in the country and probably worldwide, actually, because people are living longer and they need more complex and demanding care, and they need to be supervised, and we need to make sure that their working conditions are better so that they will positively impact the care of the clients. A happy caregiver usually leads to a happy client. Okay, so caregivers focus on the whole person, and they can be hired for many different things. The most important thing I would say is the safety of the client. So sometimes family members will say we're far away or we're working all day and mom is alone in her home and she needs somebody to take her out a little bit. She needs someone to talk to. So they hire somebody for companionship and social interaction. And certainly we understand today in this COVID world that social interaction is really important. Personal care, of course, depends upon the ability for a person to take care of their activities of daily living. And we want to make sure that the person is clean and well fed. Mobility, of course, is really important. People's balance to make sure that they're safe when they're walking. Laundry and light housekeeping to keep the home safe and clean. Meal preparation, it's not just to have a chef in the house, but really to make sure that a person is eating properly, that they're doing some physical activity, that they're taking their medication properly, and that their healthcare providers are involved in their care as well as their families. And of course, they can run errands or they can take their client to appointments. So those are some of the things that a caregiver does. And people are hired for many different types of, as Karen had said earlier, amounts of time. So we provide live-in care. That means somebody stays with them 24 hours a day. And usually we recommend that there's an on-off schedule because they're required to also have some time off. So somebody who lives in might work for 11 days in a row straight, and then they'll have 3 days off. And during that situation, the agency provides a replacement for somebody who needs that live-in care. There are some people that are fine at night, and they just need somebody with them during the day. So there can be long hours, 12 hours, or 8 hours, or 4 hours is our minimum in most cases. Some people need care overnight. They wake up many times during the night and they need somebody to be there to help them go to the bathroom or to be with them at night. And so we have another kind of shift, which is called an awake overnight. They do not sleep during that time. They're there to make sure that the client is safe and cared for. There are short hours, there's companionship. And even during this COVID time, we've had people that just are hired to do shopping for a family. Go shopping, pick up a list, go shopping, and bring the food to them. They really don't want somebody in the home, but they can't take care of that by themselves. So those are some of the types of things that a caregiver might provide. The agency in general, I sort of try to put in a chart for you the kind of things that a home health agency will take care of. And Karen alluded to the fact that when somebody hires privately, there are many things that they know that they're not aware of that get taken care of by an agency. And an agency is generally more expensive than hiring somebody privately, but you have to really understand what the agency is taking care of. So knowing and following state regulations and getting the right certifications. Just so happens that this week is our annual certification. where there's an organization that comes to evaluate and to make sure that everything is being done properly in accordance with the state regulations. New Jersey says that caregivers need to have a number of hours off a day, or that they need to be able to sleep a number of hours at night. It talks about what needs to be done for a client, that there needs to be a proper care plan. So we have to follow these state regulations, and we have to get this certification, or we're not able to do our work properly. And we're not actually able legally to work. In the process of hiring caregivers, there's an assessment of skills, which is done by our nurses. We do background checks, bonding and insuring of the caregivers, and we take care of payroll, taxes, and any legal issues. Training of caregivers is really important, and evaluating them. We do evaluations of every single one of our caregivers twice a year. And certainly we check in on them on a very regular basis. And Karen will talk a little bit more about the regulations of checking in on our clients and our caregivers. Supervising the caregivers on a regular basis is done by our nurses and by our social workers. And scheduling. Scheduling is probably the most complicated thing. I think we all know that in our lives, they're not exactly the same every single day. And that's true for all of us. So our schedulers need to really know the schedules of the client's needs and also the schedules of the caregiver's needs. They need to be able to match the right person, the person who wants to have somebody who's very, very chatty with them because they like and enjoy that kind of conversation, and the client who really doesn't want somebody chatty. They want somebody who's going to do their job and be quiet. You need to have a matchmaking based on the skills of the client and of the caregiver and the needs of the client. You need to match the personalities. You need to match the actual timing. And it's a very, very complicated process. We have two that do it, and I'm always amazed at their capability. Of course, there's continuous agency evaluation, and there's continuous communication with the family, with the client, oversight, and of course recommendations, because things change. When you have somebody who starts with a little bit of care and then their situation changes, we need to hear from the family, we need to hear from the client, we need to hear from the caregiver to make sure that we're doing the right thing for the client. And on the part of the family, when you're selecting an agency, there are things that need to be done, and that is you need to know what it is your needs are. So the family and friends and medical specialists have to give input on what is the right thing. And then you have to assess the actual and the realistic abilities and needs. So sometimes we hear from a family that has a caregiver for many hours or a live-in, and then they say, well, this is getting very expensive, and we need to cut back. And they go from a live-in care situation and they want to go down to no care at all. And we have to really understand, they need to understand, and we need to understand what is the real ability and capability of that person, and help find the right set of the right care during the right timing. You have to understand your financial needs. Care is not inexpensive. But there are ways to help people find the finances. In some cases, if somebody wants to stay in their home, there are things like reverse mortgages. There are also programs, and we're going to be doing a program for you next month on Vet Assist. It's a special program where the Veterans Administration covers the cost of some healthcare needs. So we're going to be talking about that later on next month. Then there's contacting a reputable agency, and then asking lots of questions. So I've prepared some types of questions that you want to ask. So you want to ask, what are the services that you provide? Can you make arrangements for any kind of special equipment or materials that I might need? What are the care team members' qualifications? Do they have a complete background check and special training? How long have you provided home health services? Are you inspected by an outside organization? When was the last inspection? And how did the agency do on those inspections? Are there patients or caregivers or healthcare professionals who recommend the agency? How do you measure quality in your caregiving? How do patients and families rate you on home health care services? What happens if I have an issue? So one of the things that we tell families and our clients is, if you have an issue, then please tell us, because if we don't know about the issue, we can't do anything about it. I'm going to say something about the matchmaking. So, we put in a caregiver that we think matches the needs of a particular client. And sometimes it does, and sometimes it doesn't. One of the blessings of an agency is that they can call up and say, she's doing her job well, but the personality, she's just not my kind of person. Can we get somebody else? Oh, and I do want to mention, I say she, but we do have male and female caregivers on staff. So do you have staff available 24 hours, 7 days a week? Who's on call? Who am I going to speak to if I have an issue? Issues happen. Somebody falls. Somebody needs to go to the hospital. Somebody is not eating well. Those things happen 24/7. They don't happen from 9 to 5. We have people on all day, all night to answer those kind of issues. Let me see what other questions I think I'm going to suggest. How much will healthcare services cost? What insurance plans do you accept? Are there any additional fees? So sometimes there are additional fees for which we don't charge overtime for our caregivers if they're hourly and then they go over the number of hours. We don't charge for that, but there are additional costs if it's holidays. Weekends are the same as our regular. There are special fees for live-in and hourly care. How soon after discharge can a caregiver start? So one of the things that happens, as Michelle alluded to earlier, that some people don't really want to think about home health care, and we can get a call at 3 o'clock in the afternoon saying, my dad's being discharged from the hospital and I need somebody to be at the house tonight. Can you get me somebody? And we work hard to do that. And I would say that most of the time we are able to do that. We're quite responsive in that situation. And of course, people's schedules change. And so we try to meet their needs. People go on vacation, both the clients and the caregivers. So we have to work with their schedules on those things also. How often can I expect a nurse to check on me? Are you an accredited agency? Do you have a personalized care plan? How often is that care plan updated? So these are some of the types of questions that I would recommend. And of course, continuous communication with the agency helps give the best care. I will go back. Karen, I turn to you.
So I'd like to talk a little bit about who are our caregivers. And first of all, there is a certification, as Randy said earlier, for caregivers. They have to be hired by our agency, they have to already be certified. There's a training program. There are a couple in our area that grant certification, but that isn't enough for Homewatch. As Randy said, we do further evaluations ourselves, and we have ongoing training for them. So a certified home health aide has a number of things that she or he has already proven to know about. But then there are kind of specialized things that we like to make sure our aides are familiar with and comfortable with. One of them is something like dementia care. We have more and more clients with dementia now, and we want to be sure that not only are our caregivers kind by nature, but that they actually have knowledge about how to properly and most effectively deal with a client with varying stages of dementia. The other thing that Randy didn't mention, surprisingly, is that one of the questions to ask in agencies are, do your aides drive? Because Homewatch is unique in that we want 100% of our daily aides, the ones who come in for shifts from 4 to 12 hours, that those aides drive. So we make sure they have updated driving licenses, and that their car is registered and insured and clean and in working order, so that we can say to our clients, yes, we can drive you to your errands, your doctors, to go shopping when it's not COVID time, to take you out to lunch, take you to the park, the library program, a senior program. So that I think that that's one of the things really that is unique about Homewatch. So asking about driving, and we also allow our clients to take their own car, to have the aide drive their car if they would prefer that over the caregiver's car. The other thing that is important, I think, to compare and contrast are the benefits that the caregivers get. At Homewatch, Randy told us that the Home Pulse always has us as an agency of choice for the home health aide. The reason is we really do pay a lot of attention to what our caregivers want. As tomorrow, as a matter of fact, there's a Zoom meeting between the owner of our agency and any of the caregivers who want to come on to ask questions, have concerns, like a town meeting for our caregivers. Our caregivers really feel heard. They feel like we've got their back, that we are trying to make, even in these COVID times, their work situation the best it can be. I think that at this point, I don't know. I'm sorry we're recording this. I feel tongue-tied. So other questions have to do with really our team approach also, that we have a nurse and a social worker for each client is something that is also unusual. And as Randy said, it doesn't appear everywhere. So what is a training for a home health aide? The training is rudimentary. It's how to give a bed bath, how to safely transfer a client who is unsteady from a chair to a wheelchair, how to set up the bedroom so that the patient has everything they need, how to do a sponge bath, how to make sure there's a balanced diet. It is basically the activities of daily living, we call them, the things that clients need universally: to bathe, to dress, to eat. And then our additional training, as I said, is more specialized. And we do these trainings intermittently through the year. Some of them are compulsory. Every single person has to take training on COVID precautions. Every single client has to understand how to safely move a patient. But then there's some that are specialized and up to the aide to decide whether or not they're interested in that. Like, what does it mean to keep kosher? Because so many of our clients do keep kosher. And then we know who have been the kosher trained caregivers so that our matchmakers can make that match. The nurse also comes out right at the beginning of service in order to write what we call our nursing care plan. A care plan is a checkoff list that is individualized for each client. Oh, here's our nurses.
Here.
Here are our nurses in COVID days, as you can see. That's the three of us. Each client has one nurse assigned to them. And that nurse shows up on the very first day of service or the day before to prepare, talks with family, talks with the client about what exactly is needed for this client in this case at this time. And we itemize it. This person is able to take a full shower but needs help into the shower. There's a shower seat. We check that off. The client would prefer more privacy. Please stand outside the door when she's taking a shower. Or this client needs hands-on assist even in the shower. There is always a range of the amount of assistance in every one of these activities. This client can dress herself, so you don't check off dressing. But if they need help tying their shoes or they need help with buttons, that is something that we put down on the care plan. Does this client take care of her own medication, or does she require reminders? Is there a calendar box with the medications set up by the family or by the nurse once every week to make sure that Monday morning, Monday evening are taken? And is it the caregiver's job then to do the reminders? Other things in the care plan have to do with what the caregiver what the client likes to eat or is allergic to or doesn't tolerate well. What time do they wake up in the morning or go to sleep? As much as we can find out, we being the nurses, on that first visit, we are able to most carefully itemize that care plan, and that is what leads the caregiver's day, by checking off the things that she does for that client that are itemized. In that way, we really are able to give very individualized plans to our caregivers. And we also revisit at least every 30 days. We meet with the caregiver, we meet with the client, we often talk with the client's family to make sure everything is going along. And as Randy said, sometimes there's just not a great match between a personality. And one of the things that we reassure our clients is that it's okay to say, I just am not so fond of her, and we'll make a switch. They don't have to worry about firing somebody because they're not firing them. We're just switching them. The caregiver is still employed, and the client can have somebody who maybe is better suited. So that's what the nurse does, sort of keeps an eye on the client and the caregiver, how everything is going, make sure it's working for everybody, and changing the care plan as the client changes. If the client suddenly is becoming more and more able to take care of herself, we change the care plan to reflect that so that everybody knows what the level of care needed for a particular person is. Okay, Randy.
I'll just add an example is that we had a family that we cared for a long time, and the person had dementia. And then the family members called and said, you know, the caregivers are just being a little bit short with mom, and we are not happy with that. And these were caregivers; they were beloved caregivers, the assessment was by the nurse that that this dementia had changed, and the client was more difficult and more challenging, and the caregivers and family members needed some additional training on how to deal with these changes in mom. And so actually Karen went out to the family and met with the caregivers, and talked with them about what's happening, why is this happening, and why is the personality of the client changing, and how to adjust their interactions with her. So that's the kind of ongoing training that we have to do based on the changes in a client. Sometimes a client is, we're able to move them about, and then all of a sudden new equipment is necessary, a hospital bed is necessary because their physical capabilities are changing. So our nurses will go out and help the caregiver and help the family understand these new changes. And the social workers work with the family on all of the needs. We always say that when a family member is struggling, and when an aide is called in, it means that there's a stress on the entire family unit. Even the children who are living far away are feeling lost, that they're not able to take care. And if somebody is working, they need somebody. So we work with the family unit to make sure that the care is proper and that everybody's feeling better about the care that their mom is getting. This particular time of COVID has been a challenge for all of us, for all of you, I'm sure. And we in the senior and care population, caring for seniors, had to really take this seriously because we saw the results. So I think that one of the things that we did was to, right from the beginning, early March, we started to hear about what's happening with COVID, and our nurses went out to every single one of our clients to do extra individualized safety training with every one of our caregivers and clients. And that was to review with them how to wash your hands properly, how to put on and take off gloves, how to put on a gown, how to take off a gown, what to do with that afterwards. And that was, early on. It was even before masks were something that we were talking about. We took other steps to mitigate the exposure that our clients would have, because our clients, for the most part, are more frail and more vulnerable. So those who had live-in caregivers, we asked the caregivers to stay longer, so they would be less coming in and going out of the home. Those who had longer hours during the day, we asked them, and of course the families, to turn those cases into live-ins so that there would be less exposure. We limited the caregivers that might have gone to multiple locations, limiting the exposure. We eliminated the use of public transportation by our clients. We started screening and we gave thermometers to every one of our caregivers who needed them, or even our clients who needed them, so that they could check their temperature daily. We screened them so that every caregiver that needed to, and still today, needs to check in. They have to answer questions about temperature, any symptoms that they might be having, and only then can they actually check into their client. Of course, the expanded use of PPE, the personal protective equipment, as you see our nurses with their masks on, and even till today, we have increased testing. So at the beginning, or sort of as tests became available, we were sending our caregivers to have testing taken on a regular basis. But in the past few weeks, we decided that we were going to do our own testing, and that we have more control over everybody getting tested on a regular basis. And also we are finding that we have a good turnaround time. So we're getting our results back from our caregivers in about 2 to 3 days, better than the 13 that's happening all over. And we've been following, the New Jersey regulations. So our caregivers who want to go to visit family in Georgia, they need to then take 2 weeks after they do their vacation. They need to come back and self-quarantine for 2 weeks before they can go back out to our clients. And the same thing is true of clients who are coming from out of state, from any of the states where where things are not as good as they are in New Jersey. We're following those regulations as well. So we're trying to mitigate the exposure. We're trying to mitigate the risk. Of course, it's impossible to totally do that, but we're finding that we've been able to keep our caregivers and our clients safe during this crazy time. I just have here one of the things that our nurses were not able to go and do this 30-day visit, but what they did was telemedicine, telehealth. They would check in. And because we weren't seeing them as much on a regular basis, we had weekly check-in calls to make sure that everybody was, was doing well, and to make sure that people didn't go out if they had any kind of symptoms. We put them on hold. They couldn't go out. And I, as a social worker, one of the new tasks that I took on was to deliver PPE to all our caregivers on a regular basis to make sure that they have what they need to keep themselves and their clients safe. Anything that you want to add, Karen? You're muted, Karen.
I think the important thing for me as a nurse during this time is really to do a lot of teaching, both to the caregivers and to the clients, about transmissibility, keeping up with the CDC, making sure that we are learning about how this disease appears to be transmitted, even though it's changed over these 4 months. As one of the nurses, I do a lot of talking to families, to clients, to caregivers about how we believe it's transmitted, how they can keep safe, whether or not they should have their dishwasher fixed by somebody coming into the house or not. I get questions constantly. We also have given, as part of the PPE, the personal protective equipment, we've given out many, many digital thermometers to our clients and our caregivers to make sure that that very easy way of checking one's own health status is possible for everybody to do. And as Randy said, the idea of that every single day before a shift, a caregiver has to answer 3 questions before they can even log into the system. They have to say what their temperature was that they took this morning, whether or not they've been in any known contact with someone else who is positive, and do they have any of these symptoms. It's a way for us to keep the safety on the front burner all the time. And I think that's really been a culture shift at our agency, that we are it's such a constant reminder to us that this is not normal care as we've given it before. And we have not had a single positive or sick person, patient with COVID. And I think that we're lucky, and I think that we're also skilled. That's all I wanted to add.
I have this wonderful photo of our caregivers who are all, they're really the essential workers at this time. We really appreciate everything that they're doing to keep our clients safe. I think we wanted to end with just a little bit of that home health care is, it's something that, many people have expressed that they want to spend their final years at home, and that their home is their, they feel comfortable in their home. It's something that's not new to them, but there are wonderful facilities. Home can be the best place, but it's not always the best place. There are adult communities and assisted living facilities and continuing care facilities that provide social interaction. Of course, during this COVID time, it's more limited, but they do provide extensive social action, social life. They have continuing education, and they offer so much more. And there are many, many options that people have, and each of those options is really according to the uniqueness of the person and their needs and their family needs. So, Karen, do you want to add anything about that?
No, I think that just as Randy had said, there is a particular matchmaking skill needed in finding the right aid. There is certainly a particular matchmaking skill needed in finding where a person should live. Some people do very, very well in more communal settings. They love the classes. They love the communal meals. They are outside their room all the time because they're very social. There are other people who really have never been social, don't want to be social. They just want their own space. They want their own privacy. They don't want to leave their house. Their house has been where they've lived for 45 years, and they never want to go to, quote, a place, that place. Both are right. Each person has their own personality and their own needs and their own ideal living situation. Getting a home health aide into a house is the perfect thing for a lot of people. Going to an assisted living is perfect for others. The good news is, even if you need the personal care of a home health aide, we do have people in assisted living, in senior buildings, as you can see in this slide. We go everywhere. We're not just for private homes. We can send additional support to somebody even in an assisted living situation. And those people are best served, the people who love their place. I mean, I have a client who said when she moved to assisted living, she felt like she was back in college. She has not been that happy since she left college. That would be a real pity for her to be isolated in the house, even with a caregiver. So I think that when somebody calls me and says, what should I do with my mother, assisted living or home? I start with, I can't possibly tell you that because I don't know your mother yet. Let me meet your mother and we'll explore the options. And then it becomes rather evident who does well in which situation.
And sometimes it changes. Sometimes there are people who are in a facility, in an assisted living facility, or an independent living facility, and they're able to enjoy all that facility has to offer. But as they age or as an illness takes over, sometimes it's better for them to be then back in their own home or in a home environment. So things change in people's lives, and the family needs to be flexible and try and find the best situation for their loved one, and taking into consideration the personality and the finances and the skills needed to keep their loved one safe. So if there are any questions, we'd be happy to answer them. Michelle,
I have been chatting about Dover and getting home care in Dover. I misunderstood and thought you meant Dover, New Jersey, which we don't cover, but Dover, Delaware, I would suggest the same thing that I suggested in the chat, which is to call a local hospital and speak to a discharge planner and find out who the recommended agencies are in that area.
Are hospitals allowed to make one recommendation over another? Like, are social workers allowed to do that?
Yes, they usually have to recommend more than one. You won't find a social worker making one recommendation, but they usually have a list of 8 to 10 agencies that they recommend.
And what about special, somebody's private messaging me? What about private, um, what about when it's somebody needs a ventilator, or when they need a Hoyer lift, or when there's some kind of uh, something like that? What happens then? Do you have to have a specific agency that deals with those things?
That's a great question. I'm sorry we didn't address it. Part of the specialized training of, of our aides are things like Hoyer lifts, because that's not taught
Could you
by
explain what
the
that is,
school.
Karen? Could you explain what that is?
Yes, a Hoyer lift is like a sling that somebody who is not strong enough to sit up on the edge of the bed and transfer means with assistance being lifted out of the bed, standing on her own feet, turning, pivoting, and being assisted into the wheelchair. That's a transfer. All of our aides know how to transfer. It's part of what they learn in the school, and we certainly reinforce it with safe transfer techniques. People who do not even have the strength to be pivoted from the bed into a wheelchair, but they get up every day in order to be vertical instead of bedbound, often have a Hoyer lift, which is a soft sling that is fitted under the patient in the bed while they're lying down, and then it's attached with chains to like a crane that is brought next to the bed. The aide then lifts the crane, the seat that they're sitting in, turns the whole contraption and lowers it so that the patient is now hovering over the wheelchair and then sitting in the wheelchair. And then they unattach this contraption and she's in the wheelchair. That is not used frequently, and not all aides know how to do it. That's part of the ongoing evaluation, however. As we hire new people, it's one of the questions, and then if they're going to be one of our Hoyer lift aides, we make sure we have a Hoyer lift in the office that we evaluate the aide's skill at using. So it's not an oft used thing, but when somebody has it, you need an aide to assist them. It is often rented, to answer your question. It can be rented or bought depending on what you anticipate is the need. And I think it is covered by Medicare. If not wholly covered, I think it is partially covered by Medicare.
Okay, there's another question. Can these services be provided short term? For example, a spouse who has been the caregiver may have a medical emergency who needs someone to fill in while they're recovering. Also, are any services available on an emergency basis?
Yes, as Randy said, we try to avoid services on an on an emergency basis. We try to avoid the person coming out of the hospital and needing help that evening, but we can do it if we can do it. So we're not against it. We just say 24 hours is really better than 3-hour notice in order to make your match and to get somebody out. 48 hours is ideal and beautiful. We have no contracts. So if you need help and then suddenly something changes, the daughter comes in from out of town and says, I don't need an aide, I'm going to take care of my mother. 24-hour notice of a cancellation is all that's needed for the ending of service. The changing of services, going from 8 hours a day to 4 hours a day, can be done on a dime. I mean, really, the next day you can have it be different. And yes, what you describe as just a very short-term respite care for a few days, that is something that agencies do.
Um, and then somebody's saying, what if there's a two-person lift?
When there's a two-person lift, usually there's somebody in the house who is one of those two people. But we have had two-people lifts where no one lives in the house but the client, and we have put in two aides to be there. So one would be a live-in, and the other one would be an assist for the live-in. We're very flexible. We can make do with what it is, but certainly if, you know, I have a client who is definitely a two-person Hoyer lift, and the husband is one of those people, and then the aide is the second person.
We have put in the second person, so sometimes the second person will go in the morning for an hour or two and then come back later on, if we can do that. It's more difficult to schedule 2 hours or an hour, you know, in the morning and an hour in the evening. But if we can do it, we do it. And certainly if somebody needs short-term, you know, we actually sometimes get, we have clients who will come up from Florida for a week, for a holiday, or to be with a family, and they need help for that week, we cover them for that. So if somebody's is the caregiver and then they have a medical need and they can't be the caregiver, we can just go in for the week or the 2 days or the 2 weeks and then be done.
Somebody else wants to know how much home health care would a person need when recovering from knee replacement surgery?
It depends, first of all, if the person lives alone or with another family member. Certainly with a knee replacement, somebody needs to be in the home to help that person get meals, get showered. There will be a time. It doesn't have to be an aide, but probably even if there's someone else in the house, you would want to have an additional trained person helping that person get into the shower or get bathed in some way. Very often, even if there's a spouse, the spouse or the client don't want too much personal care being done by the spouse. If somebody becomes incontinent, unable to use the bathroom, it's not ideal for the daughter or the husband to be the one changing diapers. There are certain kinds of care that even if someone is available to provide some of the care, there is personal care sometime that it's really, if it's possible to hire somebody for, because of the personal nature of it or the amount of strength needed to help lift or move somebody. That would be a case, even if there's somebody available, where you would also, I think, still want to have an additional professional.
I see Ellen's asking about if there are services that will come and evaluate a home for safety. And yes, we do have a number of medical services, OT, physical therapy, visiting nurses, visiting physicians, making sure the home is safe. We have referrals that we give out to families to help them during this kind of situation where they need to make the home a better place for safe care. And if you need a referral, we'll be happy to share that with you.
Are there any other questions?
I think that might be it.
Okay.
Alrighty. Well, that was very interesting and informative, and I hope that everyone out there got something out of that. I know it's an uncomfortable situation, but like I said in the beginning, it's something that we really need to get ahead of, because you just don't know what life's going to throw at you, right?
And the other thing is, sometimes, it seems like this is an unfortunate situation, but I'm on the side of it where I see sometimes it's delightful, that I have people who have a caregiver and they describe themselves as besties now, that sometimes the idea of it is I don't want to need help. But the reality of it sometimes is a lovely relationship and really somebody who becomes like family.
Well, that's the ideal situation, isn't it?
It is.
And some of our caregivers have really, during this time of COVID, some of our caregivers have stayed in the homes with their clients for 3, 4, and even 5 months. Some of them are just taking some well-deserved and needed vacation after 4 months, from March until now. They've been with their client when the family's not coming in because maybe the children are worried about sharing something with their mom, or they're worried about having their own medical issues and not being around other people. So our caregivers have become the daughters and the sons and the shoppers and the chefs and playing all those roles. And they develop a very close relationship. They learn to work together, and they're very much appreciated.
We have caregivers who are invited to weddings, not because care is needed at the wedding, but because they've become that kind of person. We have caregivers who go down to LBI for a month at a time with our clients because they don't want to be on vacation without their caregiver to help them. So it can be a really beautiful addition to somebody's life, even if we don't want to think about it. You are on mute, Michelle.
You're muted yourself.
Yeah.
You're muted again. No. Welcome back.
Yeah, I'm a little concerned that the ghost is back. Because that kept muting itself there. I'll explain the hat in a second. But I want to thank our guests today. I really appreciate it. And I want to just put a plug in, Randy, for you mentioned in your talk the Vet Assist. September 16th at 11 o'clock. Randy will be back with, I know you have a guest for that,
Yep.
somebody that will talk specifically about this benefit, this Veterans Aid and Assist benefit. So if you're a vet, or if you were married to a vet, is that it?
Yeah, spouse, sure.
Spousal, that you might be eligible. So come and find out. Maybe if you're not a vet, maybe you know somebody that is, and you can get the information and pass it along to them. And then after that, we have another program that's related to this on the 30th of September, another 11 o'clock wellness lecture on PT and OT. Instead of going out to facilities, that's done in-house, in your home. Is that right, Randy?
Yes. Yeah.
So,
yeah.
So
it can be done also virtually if people are more comfortable. I think that Karen can attest to the fact that even while our nurses are now going back to doing their home visits, there are still some clients that are uncomfortable having someone come into their home. And so Karen does it through telemedicine.
Yeah, yeah.
Um,
So that'll be on September 30th. And then another plug, one of Randy's connections is another Money Talk, right?
yeah,
And who's doing that? Is that
Michael
Michael?
Coco.
Michael Coco. Michael Coco was here a couple months ago at the beginning of August, and he kind of kicked off, and he was fantastic, and we all said he should have his own TV show. So episode 2 of Money Talk, and maybe talk about some of the more specifics on how you can save for the future and how you could prepare your finances so that you could afford home health aid and not go into a facility if the need arose. So, but I want to thank both Karen and Randy for coming, and I really appreciate it.